I'm going to talk about current research, or current developments of research in leukemia. I'm going to talk predominantly about ALL, the commonest leukemia in children, at 350 cases a year. So of the 30 cases a week, about 10 are leukemia of some kind. First, I'm actually going to talk about football. I'm going to talk about this because this is going to be discussed ad nauseum in the next month or so in this country. And to me, the real heroes of 1966 are not these guys, but the guys on the right. These are the guys, particularly the gentleman on the far right, Don Pinkel, who in 1964 persuaded a group of parents to expose their children to cranial radiation to prevent leukemia returning in their CSF fluid. At the time, there was absolutely no evidence that this would work, and leukemia was an incurable disease. At the time, he just talked to some parents, they did it, and the cure rates went to 50%. Now, you have to go through an ethics committee, some form of regulatory board, and various other things. And I seriously wonder whether we've actually been allowed to do this now on the level of evidence that exists. So one of the things, if we're talking about research and parent advocacy, is it's very, very important to get parent advocacy around the kind of thing that Steve was talking about, having real enthusiasm to do things. So I shall move on from that and show you what Pinkel and his colleagues achieved. We went from a situation in 1966 where childhood leukemia was incurable to 2014 where survival in ALL in this country is 92% and survival in AML is 72%. This is a remarkable achievement because there haven't been any new drugs for lymphoblastic leukemia since 1970. And what we've achieved is by just changing the way we give drugs, just changing the way we schedule them, and looking at and inviting parents to be involved in randomized trials, we've improved prognosis. It's a stepwise improvement. There was a sudden step there in 1972 from 0 to 50. A little step further when all we did was just persuade families to keep taking the treatment, not to have breaks, but to just take the treatment. But it was induction, strong therapy for a month, cranial radiation and maintenance, 2 years of outpatient chemotherapy. In 1990, we introduced what's called intensification, which is what the other gentleman that I showed you the picture of, a guy called Hans Riem, invented or developed in Germany. He said, too many people relapse, let's take all the drugs we know, give them all together over an 8-week period. It was in a room about this size, everybody stood up, walked out, thought he was mad. It's given all around the world. It's named after it now. But again, it's the same sort of thing, just having an idea and doing something different. By 1999, we'd reached survivals of about 85%. Event-free survival means the chance of being cured and never relapsing. Overall survival is the chance of having ultimately being cured. So there's a small group of patients whose disease returns, but they're able to be salvaged and ultimately cured. The blue box is the difference. It's the group of how many patients can be salvaged, and it's a very small box. And that's very important because when you're thinking about treatments to reduce toxicity, you have to remember that you really only get one go. Salvage is expensive, it's very dangerous, and it carries quite a lot of side effects. As we got better, we've intensified our treatment. As we intensify our treatment, we increase the number of patients we overtreat. At least half of the patients that we treat today could be cured with the gentle regimes that we used in the 1960s and 70s, but all get much stronger therapy. So what we need is what's called risk-directed therapy. We target the treatment to the patients at high risk of relapse. And we do that in two ways. We do it by what they look like at diagnosis. So how old are they? The older children need stronger therapy. And how high the number of white cells at diagnosis? The higher count needs stronger therapy. We can also very quickly look at the genetic changes inside the leukemia. Leukemia is not a genetic disease. It's not a congenital disease, but it is a disease in which the genes change in the leukemia cells to give them the growth advantage. And we recognise some good gene changes, we recognise some bad gene changes. And nowadays, we measure response to the first month of therapy, and that's what MRD, or minimal residual disease, is. I have a very simple brain, so I explain it like this. At diagnosis, the bone marrow is full of bad cells. There are 1 or 2 normals, which give you the few platelets and the bit of hemoglobin you've got left. At the end of the first month, your marrow is generally happy. I think I've drawn this about 450 times for parents. I do this all the time. And you've got a few bad ones left. And I often talk about the bone marrow being a factory, and the factory being full of the wrong things, and then starting to work again when the treatment works. Hiding in the cupboard are 1 or 2 bad guys. And if you don't know how many are in the cupboard and you don't give enough, they'll come out of the cupboard and they'll fill up their bone marrow. That's what they'll do when the treatment starts working. So MRD allows you to work out how much is left at the end of the first month. And in our last MRD trial, half the patients, the test was negative, which means that the leukemia has gone below a level of 1 in 10,000. These children have a less than 5% chance of relapse and an overall survival of 98%. These children have as much chance of dying from the therapy as they do of dying from the disease. And that has incredibly important implications that have nothing to do with biology and everything to do with good healthcare. The treatment in these children can be safely reduced while maintaining survival. By contrast, there's another group of patients, and Bruce alluded to this, who have had a slower response, and that's where our relapses come from. But the difficulty is that many of those children, even though their MRD is still positive, still have a 90% chance of cure. So it's not a particularly great test for picking out who's going to do truly badly, but it does allow you to pick out the group you might give slightly stronger therapy for. So we used MRD in our last trial, ALL 2003, which closed a couple of years ago. This is a plot of where we are compared to the rest of the world. And I show this for an obvious reason. The UK is where St Jude, which is the research hospital in the US, is. The UK's results in ALL are the best in the world. But what I also show this for is to show that everybody does reasonably well, and that everybody has survivals in the 80 to 90% range. And that I agree with Bruce that our old drugs still have mileage, but we are beginning to see a plateau. And we need new research, we need new biology. We're running now a trial which looks at what we did in ALL 2003. It shortens the exposure to dexamethasone, which is the steroid at the beginning, to try to reduce toxicity. It uses a higher dose of methotrexate, like what was used in osteosarcoma, to try to reduce the risk of disease returning in the CNS. And it changes maintenance. It takes away the steroids and vincristine. I don't know if anyone in the room whose child's been treated for ALL, but most people who have had a child treated for ALL dread the 5 days of steroids every month. So that's our new trial. I wrote it in 2007. It opened in 2010. It costs £1 million. The cost of the NHS of treating ALL is £145 million during that time. And it took me all of that time to get the money and to get it through ethics. And that's the reality for us as cancer doctors in the modern era. What will happen, as I've said already, is I think our survivors are plateauing. So we need some new biology. We need to reduce treatment-related mortality. We need to understand the biology of our disease better. And we need to harness the power of the immune system. And I've got some brief examples of how we do each. This is what children die of if they die of treatment in ALL. 77% of the deaths are due to bacterial infection. You could argue that every single one of those is potentially preventable. 1 in 3 deaths in ALL are now treatment-related. Only 9 of every 100 children with ALL will die. 3 of them will die because of treatment, because of infection. We've tried to get around that by changing our scheduling, by stratifying therapy better. We could also look at the genetic risk. We are all different in the way that we deal with infections. Some of us will be laid low by exactly the same virus that the rest of us just wander around with. We're all different. But what we really need is in-depth analysis at a healthcare level of why patients die. There's a precedent for this: perioperative deaths, obstetric inquiries, various other things. So we've come together as a group of cancer doctors, oncologists, solid and brain to try to fund that, to try to drive that forward. It was very highly rated, but we didn't get funded. We were in a lot of competition with other people. But this is one of our pressing research priorities. The second thing we need to do is to understand how we all deal with drugs differently. And we now are beginning to measure how well exposed our patients are to their drugs, particularly to a drug called asparaginase. Key drug, if you get enough, it's great for leukemia. If you get too much, it's bad for the patient. And we're starting to measure that in real time. We're starting to understand how to give it. To be fair to Steve, it was something that he talked about many years ago. And as we've got that right, we've improved our cycles. The third thing we've done, and we've been doing it for a long, long time, is look at the biology of our disease. So we look at the genetics of all our leukemia cells. We paint the cells different colours, or the chromosomes different colours. A few years ago, we were looking for a swap between chromosome 12 and chromosome 21. It occurs in about a quarter of the patients. It has about a 95% survival, so it's a good disease, one we might use therapy for. A small group of patients seem to have lots of copies of the extra gene on chromosome 21, and we called it internal amplification of chromosome 21. We looked at the outcome, and it was about 20%. And these patients were just slowly relapsing. So we thought, in our next trial, we need to give them stronger therapy. Their outcome now is 85%, just from discovery, those few little dots. We recognise a disease called Philadelphia ALL. It's what you see in chronic myeloid leukemia, what you see in a lot of adults with ALL. It's responsive to one of the few truly targeted drugs, a drug called Gleevec or imatinib. There is, on gene expression, which means how the cells make their proteins and their genes, a disease that doesn't have the chromosome which you wouldn't know to do from cytogenetics, but you do know to do from gene expression, you get a much better outcome. So we now prospectively screen all of our patients who have had a poor response, all of our patients who are refractory to treatment, and if we find this, we treat. We've talked about quality of life. I won't go into this in depth, other than for us, in our current ALL trial, quality of life is an endpoint. So we're actually comparing two different regimes. We know the survival will be excellent. What we're trying to understand is it better to have 6 months of very intensive hospital-based therapy and then go on to maintenance and not have these pulses of incretin and steroids? Or is it better to have more time out of hospital at the beginning and then spend more time coming up to hospital during the maintenance period? We would dearly love to have some health economics. I don't think, as a field, we've made any progress with that at all, but I'm sure it's what we will need to justify our next trials. And lastly, I'll talk about how we exploit the immune system. Hematologists love the immune system, because you can draw all these pictures. But essentially, the reason most of us don't get cancer is that our immune system does what's called surveillance. It stops us getting cancer, but we get cancer, it gets rid of it. There is a way, in leukemia, we expect what's happening is the immune system can't recognise the leukemia and has lost its ability to attack it, to get rid of it. So we are now around the world using gene therapy to teach the immune system again to recognise the leukemia, to attack a protein that's on the surface of the leukemia. And if Steve was excited about what his colleagues are doing, which I agree, it's very exciting, I think this is as exciting. This is a way of teaching the immune system through gene therapy to recognise leukemia and to kill it off. This has been effective in patients with completely refractory disease, the kind of disease that I have to sit there and have the conversation I don't want to have with parents. This has cured patients with completely refractory leukemia. This is very likely to be the future. It also illustrates beautifully the future of our field. This has been bought by Novartis, by a drug company, and the access to it will be therefore very significantly restricted. And that is the modern world in which we live in biotechnology. So overall, childhood leukemia, the age of miracles, fantastic story. We are plateauing. We need to do much better research around toxicity and understand the healthcare implications of why patients die. There always has been in this field very real progress around biology. We need parental support to make that happen quickly, I think. Thank you.